So hello, good morning, everyone. At the outset, I'd like to thank AIS Scientific Committee for giving us this opportunity to present a very interesting and relevant instruction course on corneal imaging, where we are going to explore various devices available in the market and also see how we can clinically apply these in our day-to-day practice. I'd like to thank our eminent speakers for the day who have consented and taken time out from their busy practice to participate in this instruction course. We have Dr. Tushar Grover, who heads the cornea department at Vision Eye Center in Delhi and has been trained at Narayan Nethralaya. We'll shortly be having Dr. Praveen Krishna, who's the chief of cornea department at LV Prasad, Hyderabad, and is a very well-known figure in the country. And we have Dr. Madhu, who is again a very famous cornea surgeon in the country and heads the department at Sri Kiran Institute of Ophthalmology and trained at Aravind Eye Institute at Madurai and at Harvard Eye Institute at Boston. And we also have Dr. Divya, who heads the department at Aravind Eye Hospital, Madurai, and has been trained at Aravind Eye Hospital, Chennai, and has been trained at Aravind Eye Hospital, Madurai. So for the next 60 minutes, we'll be talking on all the relevant imaging devices. And to begin with, I'll on topography and biomechanics, understanding machine integration and learning what you're seeing. Be sharing my...
Sir, sorry to interrupt you, sir. You need to share your slide, sir.
Yeah. Are my slides, I hope my slides are visible.
Yes, sir.
All right.
Go ahead.
So the biggest challenge every cornea refractive surgeon come across is patients coming to us wanting LASIK with borderline tomography, and we don't know what to do. We don't know whether to actually go ahead with LASIK or LASIK extra or SMILE extra, or to just wait and follow up these patients, or to offer cross-linking. In the literature, it has been shown, and we also come across these patients who has undergone LASIK and has developed ectasia in spite of the ectasia risk score, high ectasia risk score on screening. Many patients are stable post-LASIK with recognized ectasia on the other hand. Yeah, so to overcome this challenge, we have incorporated in our practice different machines over a period of time. To start with, we were just looking at the anterior surface with the help of corneal topography, and then we incorporated corneal tomography, which used to give corneal both anterior and posterior elevation maps, and then epithelial map and Bowman roughness index, which was described as layered or segmental tomography here. And then later we switched on to biomechanics, which is of interest today. And Boolean microscopy and finite element modeling is still not very clinically practiced. So we'll be talking about biomechanics today. This was a very important contribution from Cynthia Roberts in 2000, 2001, where she told cornea is not a piece of plastic, and the cornea exhibits both viscous and elastic properties, which contributes to its biomechanical behavior. Let's understand what is the difference between elasticity and viscosity. So basically, elasticity is the ability of the body to resume its normal shape after deformation, whereas the viscosity doesn't regain the original shape, and there's a dissipation of energy. Biomechanical changes precede morphological changes, and this has been the basis of incorporating biomechanical indices in our practice, because we want to detect these ectasia as early as possible, so to offer patients better safety after all these laser visual correction procedures. So to start with, healthy cornea is there, then it undergoes stress and strain, and then later we'll see a change in elastic modulus, which then over the period of time manifests as biomechanical changes, which can be picked up by newer devices like Corvus ST. Then over a period of time, we'll start seeing these changes in tomography maps, and then over a period of time, it starts manifesting in topography maps, and then slowly we start seeing these patients on SLIT-LAC. So Corvus ST is the most commonly used biomechanical device in the market, and it's the second generation update in this machine. And it's basically a non-contact tonometer that monitors the response of the cornea to an air pressure pulse in real time. It uses an ultra-high speed time-flight technology where the images are captured around 4,000 frames per second. The captured image sequences are then used to estimate the IOP and deformation response parameters. This is one of the display which is shown by, given by Corvus ST, and almost like 16 dynamic corneal response parameters are captured, and you can see how it is displayed here. There's another report which is given by Corvus ST, and it's called Vinciguerra screening report. At the bottom right, you can see some 5 boxes which we are going to talk about. So the DA ratio, integrated radius, and the SPA1 are deformation parameters, whereas the Ambrosio relation thickness is a thickness parameters. And CBI is basically a mix of these parameters, and it shows a color-coded box. So a cornea is stronger or is stiffer when DA ratio and integrated radius is lower, whereas ARTH and SPA1 is higher, then the cornea is supposed to be a stronger and stiffer. Corneal biomechanical index was developed using linear regression analysis for detection of keratoconus with high accuracy. It incorporates 6 deformation parameters along with one thickness parameter, which is called Ambrosio relational thickness. Now, Ambrosio relation thickness parameter was added to a corneal biomechanical index because it was shown that it increases the accuracy of CBI to many-fold. So with a cutoff value of 0.5, CBI has corrected classified around 98% of the keratoconus cases. Let's see an example how CBI can be useful. So if you see on the left side, the map shows typical keratoconus, and on the right-hand side, the map doesn't show any changes in favor of even a subclinical keratoconus. But if you see if you see the corneal deformation parameters and CBI, they are all abnormal, as obvious because the cases of keratoconus. Whereas if you see in the right eye, CBI is abnormal, but the maps are normal. So that means these cases are actually could be classified as formifus keratoconus because biomechanical changes are already there. And these are the cases which were missing earlier. This is another update in the Corvus ST where you can see a biomechanical comparison display, which is basically used for the cases where we have done cross-linking and we want to follow these cases. It's a very objective, it gives a very objective results, like all the deformation parameters. They'll give you whether cornea has become stiffer or it's not significant or it has become softer. Also, it also gives the SSI index, which we are going to talk later. And it also shows the cornea has become stiffer in this case. Let's come to tomographic biomechanical index, which is nothing but the integration of biomechanical indices from Corvus ST and tomographic parameters from Pentacam. And together they comprise tomographic biomechanical assessment. So TBI was shown to have highest sensitivity for detecting subclinical ectasia among eyes with normal topography in patients with very asymmetrical ectasia. A cutoff value of 0.35 correctly classified all ectasia cases from formifus to frank keratoconus. If you see an area under the ROC curve here, and when compared to CBI, BAD-D, and TBI, TBI was shown to have maximum area, which just shows that it has the highest sensitivity. This is a typical display from a tomographic biomechanical assessment. You see a TBI, you have a CBI, and you have a BAD-D, and it has a very clear-cut color-coded display. Now let's come to the global consensus on keratoconus. What it says true unilateral keratoconus doesn't exist, but secondary induced ectasia may be caused by a pure mechanical process and can be unilateral. Every day, once in a while, or often, I'll say, we come across patients where we think it's a case of true unilateral keratoconus, but the maps doesn't show anything. So these cases can be classified as very asymmetrical ectasia or very asymmetrical ectasia with normal topography. Let's see an example here. A 17-year-old boy, where you see in the right eye, the maps shows keratoconus, and all the parameters like CBI, BAD-D, and TBI also are in favor of keratoconus ectasia. And whereas in the left eye, the Pentacam maps are totally normal, and BAD-D, CBI are all normal. But if you see a TBI, it is elevated. So again, this case can be classified as a case of unilateral unilateral ectasia, but since it doesn't exist, so these cases are the cases which can be classified as formicous keratoconus or very asymmetrical ectasia. This was a very interesting paper from Ambrosio et al., where they showed subclinical keratoconus detection in identical twins. So if you see on the top, if you see the top photos from twin 1, if you see the right eye shows, the map shows, the pentagram map shows signs of keratoconus, and TBI was elevated as expected. Whereas in the left eye, you show the maps, you see the maps are normal, but the pentagram, the BAD-D is slightly elevated, but TBI is definitely elevated. And if you see twin 2 right eye, the maps looks perfectly normal, except that the TBI is elevated. Whereas the left eye also maps are perfectly normal, but the TBI is elevated. So the first case you can classify again as very asymmetrical ectasia, and the second case, twin 2, can be classified as subclinical keratoconus, which is genetically predisposed to develop keratoconus, but probably it is missing a second hit where the environmental factors are not present. This is another index which is recently given by Colin Sestri, and it's called stress strain index, and it's a material stiffness parameter. It's a non-invasive measurement of a true biomechanical parameter in vivo. Very importantly, it's independent of IOP and CCP, and it's dependent on age. SSI was taken as 1 for the corneal tissue with age 50, and higher value indicates higher stiffness. So if the curve moves towards the right, it becomes softer. If the curve moves towards left, it becomes the cornea becomes stiffer. And it measures global response and doesn't map the location of the disease. It's not a diagnostic tool. It basically tracks the progression of ectasia. It allows us to decide timely intervention, especially in borderline thickness, especially in pediatric patients. And it monitors the response to therapeutic interventions like CXL, where you'll be able to know whether CXL has become successful or it's a failure. It can be a useful tool to distinguish due to topographic artifacts like epithelial and remodeling. CBI LBC is another new index which has been added, and it's helped differentiate stable post-laser visual correction eyes from post-laser visual correction ectasia. So basically, till now, what we were doing was all these patients who have undergone LASIK or any refractive procedures, we were trying to see BAD-D, CBI, and TBI when we are suspecting ectasia. But these indices will always give you abnormal readings because there is a flattening and thinning of corneas in these.
Please wind up.
Yeah, it's just 1 or 2 slides more. So basically, BAD-D and TBI, CBI in post-laser vision correction eyes were giving abnormal reading, and to overcome those challenges, CBI LVC was another indices which was added recently, and it's a purely biomechanical index as it does not include shape or pachymetry indices. A cutoff of 0.2 showed a sensitivity of 93.3 and a specificity of 97.8%. So in summary, I would say biomechanics can become an essential component of the armamentarium of tests for screening of refractive surgery candidates. CBI and or TBI can detect subclinical keratoconus, and SSI is the single most important index for comparing the outcomes of interventions like CXL and LASIK extra. I would like to conclude that integration of the machines for a better diagnostic ability is the way forward, and there cannot be a single index which can definitely distinguish between disease and normal for such a complicated entity. Thank you so much.
Thank you so much, Dr.